So in this PowerPoint, I'm going to describe what a heparin bridge is and the things that we're looking for. So the two main medications we're going to talk about here, heparin, unfractionated heparin. When somebody is on a heparin drip, and this should really say heparin drip, so we're talking about IV, the blood monitoring for therapeutic levels is the APTT. Some hospitals will use the anti-factor XA, but I have not seen that happen on the boards. So the therapeutic APTT is 46 to 70. That's from your textbook. But I see questions out there saying that they want you to know that an APTT of 70 is considered critical to high. So really think that 71, so on. If you have somebody a question that's saying APTT of 70, and it is kind of getting you to figure out, what would you be concerned about? You might be thinking that's too high. I'm not going to try to trick you on an exam, but I have seen questions using 70 specifically as high. Now, the reversal agent for heparin is protamine sulfate, and then warfarin, which of course the trade name is Coumadin. We're talking about oral warfarin here. INR is generally the therapeutic monitoring. They do talk about pro-time INR, but I can't find any numbers saying where we want that pro-time to be because the INR is really what we look at. When somebody is on warfarin, we want their INR usually to be somewhere between 2 and 3. And remember, somebody who's not on warfarin, the INR is the normal is like 0.8 to 1.1-ish. Sometimes we'll want the INR as high as 3.5, but 2 to 3 is generally considered what we want. Now, the reversal agent for warfarin is vitamin K, but the generic for vitamin K is phytonadione. So bear with me, this probably looks like a hot mess if you weren't in class when I went over this. So we're going to pretend we have a patient who is admitted with critical limb ischemia. And so on day 1, the patient's brought into the hospital. They have this limb that has not great pulses, doesn't look good. So they start them on a heparin drip, meaning that IV drip. They're going to check the APTT 6 hours later. And in this scenario, we're going to say the APTT is 50, so that's therapeutic. Then they need to do another one 6 hours later, and it's 51. Once somebody has 2 therapeutic APTTs, they then just go to daily. And so during day 1, this patient's just undergoing testing. They're trying to figure out what they're going to do with this patient. So on day 2, the patient's heparin drip is still going. Their APTT is 50, so still therapeutic. They now decide that the patient will need surgery at a later date after the infection is improved, and they're going to need to send them home on anticoagulation they can be at home on. We don't send people home on heparin IV because it could be so dangerous. So on day 2, the INR that morning was 0.8. They go ahead and give the warfarin, and now it's day 3. So day 3, we're really just waiting for the INR to be therapeutic. They're still on that heparin drip, that IV drip. Their APTT is 52. Again, these are all hypothetical numbers. They give another dose of warfarin. And this morning on day 3, the INR was 1.5. So we're still not quite therapeutic. Now, day 4, they're still on heparin. We're still waiting for that INR to become therapeutic. Their APTT is 55, and so the INR that morning was 1.9, so they give them another dose of warfarin. And lo and behold, on day 5, the INR is now therapeutic. It is 2.2, so they'll be able to discontinue the heparin, and they'll send them home on warfarin, and they'll continue to take warfarin at home. Now, the reason somebody would be on both heparin and warfarin at the same time is because warfarin generally takes anywhere from 3 to 5 days for that INR to become therapeutic. And so we need them on something to keep the blood flowing for whatever the reason would be until the oral medication kicks in. Now, I do see quite a few questions out there about, a patient is on heparin and warfarin and this is okay, or where you might be teaching a patient why are they on both. And so understanding that, again, that warfarin takes some time for it to become therapeutic is those things. Now, warfarin is an inexpensive medication. It's been around a long time. Some of the disadvantages of warfarin is that patients need to have routine monitoring. Generally, once they are therapeutic on warfarin, they'll end up going to like monthly blood monitoring. Initially, it might be a little bit more frequently. And they also have to be careful to eat the same amount of vitamin K in their diet every single day. And so if this person, eats a spinach salad occasionally, that's going to be a problem if they don't have any other of those green leafy vegetables. So we're going to want to teach them that we don't want to give up those really nutritious foods, but teaching them how to get the same amount in every day is going to be important. And so we might help them and give them a list of foods that are high in it, medium, and we might end up getting a dietitian involved to help them with that teaching. Now, there are some options besides warfarin for patients. Factor XA inhibitors like apixaban, which you may know it as Eliquis, or rivaroxaban, which you may know it as Xarelto. The benefit of these medication is there is no therapeutic monitoring for an INR or APTT. Now, they do still need to have their CBC monitored periodically to make sure they're not bleeding, and they will often have their creatinine monitored. But no food interactions, no INR, PTT monitoring. But the problem with these medications is the cost. They are very expensive, and so not all patients can afford to be on these medications. They do have a reversal agent. It is andexanet alpha. But so this is just another option as far as the teaching and what we would need to know about these medications. So I hope this was helpful. And if you have any questions, as always, let me know.